Good afternoon. Pre-lunch session, and we'll just start with the first presentation. We have special situations. Use of steroids in diabetes, challenges and solution by Dr. Aarti Kannan. So, ma'am is a postgraduate teacher in medicine for the past 14 years, national faculty in Tapicon, GCDC and TRAC. And she's a scientific committee chairman of TRAC 23, referee for Journal of Association of Physicians of India, Martho Natchatram Award in 2023 by Tamil Nadu IMA, treasurer of Tuticorin in IMA, treasurer of Midterm Conference DAISICON, co-editor of GCDC Update Book, and published articles in various journals and contributed various chapters. Over to you, ma'am.
Thank you, ma'am, for your introduction about me. Respected leaders of the profession, chairpersons, co-speakers, a very warm good morning to all. At the outset, first I'd like to take this opportunity to thank the organizers of DAISICON2025, especially Dr. Shanmugam sir and Anand Moses sir for giving me this opportunity to be a part of this prestigious conference, and as a faculty, and to speak on the use of steroids in diabetes, the challenges and solutions. A big thank you to Professor Madhavan sir, Gauri Shankar sir, for they have made my work very easy. Already steroids has been discussed. Let me just give a gist of it and close. So, this steroids usage is actually a big challenge for all physicians for our diabetic patients. The prevalence of steroid use in diabetic patients, up to 40% of hospitalized patients do receive glucocorticoid therapy, and 32% of type 2 diabetic patients require steroid treatment at some point of time in their diabetic care journey. And steroid-induced hyperglycemia has found to affect up to 60% of non-diabetic patients, and new onset steroid-induced diabetes has found to affect 21% of previously normoglycemic individuals, which is indeed a big data today. So the glucocorticoids in clinical usage nowadays are short-acting as the hydrocortisones, intermediate-acting prednisolone, methylprednisolone, triamcinolones, Deflacort, and the long-acting dexamethasone and beta-methasones. The long-acting ones are the ones which cause prolonged hyperglycemia due to the prolonged gluconeogenesis and increased insulin resistance compared to the short-acting ones. So the mechanism by which this glucocorticoids actually cause hyperglycemia is it acts on the liver, increasing the gluconeogenesis, so it decreases insulin sensitivity, acts on the beta cells, increases the glucagon, so it also acts on the muscles, reduces the glucose uptake, decreases the muscle mass, acts on the gut, increases the incretin effect, acts on the fat cells, increasing the leptin levels, acts on the central nervous system, increasing appetite and leptin resistance. All this leads to the production of hyperglycemia, ketonemia, and more of osmotic diuresis, leading to diabetic ketoacidosis. So once a steroid treatment has been commenced, if we have a blood sugar of greater than 200 in 2 or more occasions within 24 hours, and the patient has some pre-existing diabetes, then we say the patient has some steroid-induced hyperglycemia. If the patient is not a diabetic, then it is steroid-induced diabetes. And these glucocorticoids have found to affect the postprandial levels. So we will have more of a spike, more in the afternoon and evening, more in the mornings. So the intersection of steroids and diabetes, steroids are powerful inflammatory, anti-inflammatory and immunosuppressive agents used in diabetic patients for various conditions like exacerbations of asthma, COPD, COVID, contact dermatitis, adrenal insufficiencies, inflammatory bowel diseases, rheumatoid arthritis, leukemias, mucormycosis, diabetic cranial neuropathies, both central and demyelinating disorders, organ transplants, etc. So the therapeutic benefits of steroids for our complications: in nephropathy, it is found to reduce inflammation, glomerular lesions. In neuropathy, it is found to reduce the neural inflammation and pain in selected cases. In retinopathy, it is used as an intravitreal steroid implants for macular edema, and in foot ulcers for topical applications for refractory cases, and in Charcot arthropathy for the management of acute inflammatory phase. So those at risk of developing hyperglycemia mainly depends on the type and dosage of glucocorticoids. Increased age, more BMI, CKD, smoking, hypertension, concomitant immunosuppressive therapy usage, race and ethnicity also do play a role. Pre-existing type 1 or type 2 diabetes, family history of diabetes, GDM, previous IGT, polycystic ovarian disease, previous history of hyperglycemia of steroid use also. So what will be the metabolic consequences of the steroid therapy in diabetic patients? It causes hypoglycemia, DKA, suppression of the hypothalamo-pituitary axis, increased HbA1c levels, central adiposity, muscle wasting, weight gain will be there, more chances of infection, delayed wound healings, acne, osteoporosis, increased fracture risk, cataracts, glaucomas, myopathies, increased cardiovascular risk, heart failures, atrial fibrillation, increased atherosclerosis. So this is a vicious cycle of worsening of the metabolic health which requires proactive management strategies. Going on to the challenges with the monitoring, the common pitfalls are inadequate testing frequency and wrong timing of the glucose measurements. Because postprandial is the level, it's actually steroids are going to increase, so fasting is going to be normal. There is no use in measuring the morning values. And the failure to account for the steroid pharmacokinetics too. So how are we going to monitor in patients without pre-existing diabetes? You need to do it at least once a day, pre-lunch or before the evening meal. If the sugar is greater than 216 in 2 occasions within 24 hours, we need to up-titrate and start treatment with insulins. If the patient is a diabetic, you check the sugars 4 times. 4 times before meals and 1 before bedtime. Still greater than 216, start treatment immediately with either with insulins. The other challenges will be with the anti-diabetic medications, what you are going to choose for a steroid-induced hyperglycemia. So as you know, sulfonylurea is more prone for hypos, DPP-4 has limited efficacy, and the newer agents available with us like the SGLT2, euglycemic decay is more common. With insulin, we do not have a fixed regimen. We need to keep monitoring, taper the doses, and there are chances of hypos when the steroids are tapered too. The other challenge is steroid-induced weight gain. As you know, it causes increased appetite. Because of that, there is weight gain, worsening of insulin resistance, higher insulin requirements, further weight gain, the reduced physical activity leads on to more of weight gain. So it becomes a vicious cycle. It also causes fluid retention and protein catabolism in the extremities. So when we monitor, we're not going to monitor only the blood sugars, we're going to also screen for all the complications we are expecting. So other than the basic glycemic control, you do a X-ray test. If the patient has a tuberculosis, it is going to be flared up. We should prevent DKA. CGM can be used for that. Adrenaline insufficiency, if you're actually contemplating it, look for serum cortisol levels, CV monitoring, do an ECG, echo, any changes are there, keep monitoring the patient every month. And lipid profiles too, and for myopathies and musculoskeletal injuries, look for muscle damage. For myopathies, a simple hand grip test in the OP will be very useful. Bone health, do an BMD, avascular necrosis, look if the patient complains of sudden onset of severe pain, radiating pain, you do a CT on MRI, rule out this pathological condition. Ophthalmic monitoring, look for cataracts, and also for intraocular pressures need to be measured. So the target CBG levels we are going to maintain. If it's an ICU, let it be between 140 to 180. In the wards, let it be less than 140. Elderly patients, home care residents, let it be less than 200. So solutions start with the dietary modifications. You need to actually distribute the carbohydrates. Let it be more with the morning, let us shift the carbohydrates more to the mornings than to the afternoon, evenings when we are going to have a spike of hypoglycemia. Proteins, we need to take more of proteins in order to preserve the muscle mass, and it also aids in satiety. Meal planning, ask your patients to take small, more frequent meals and early dinner so that we can prevent the overnight hypoglycemia. So the treatment approach to steroid-induced hyperglycemia, whether it is a type 1 or type 2 diabetic patients, if the patient is on basal bolus or a pre-mixed insulin, keep monitoring the blood glucoses. If needed, add short-acting insulins too. In type 2 diabetic, not on insulins, if they are on insulin, basal or pre-mix, monitor the glucose, add short-acting if needed. If they are not on insulins, you can add an OHA, still not under control, you can start intermediate-acting NPH insulin too. So for inpatient recommendations, we had a 40-minute talk on this inpatient recommendations. I'm not going to talk down detail on that. So it's the same, if the pre-existing diabetes or not, look for that. Keep monitoring the blood sugars. Strict glycemic control is very much needed. Similarly, in outpatient also, rule out if the patient already has a diabetes or not. Non-diabetic, rule out all the other risk factors present and start OHAs, keep uptitrating the glycosides. If needed, still not under control, you can start them on insulins too. So for the preferred steroids, what will be your anti-hypoglycemic agents you can use? Short-acting ones, you can use a sulfonylurea plus short-acting insulin. Whether it is intermediate or long-acting, use sulfonylureas with NPH. Patient can afford, use an insulin analog also. So when you're going to taper or discontinue the steroids, you need to be very careful, because for IV steroid, you're going to stop within 24 hours, the glucose levels will drop. If an oral drug, if you're oral steroids, you're going to taper over the weeks, sugars are going to decrease only over the weeks. And we also need to taper the anti-hyperglycemic agents also. Steroid tapering, you need to educate the patient really well. You're going to discharge the patient, along with the attenders also should be very much educated. You must tell them that the patient is on a tapering dose of steroid. As we stop the steroids, the glucose levels are going to come down. 12 weeks after full stoppage, do a full glycemic package for the patient. So another solution is using alternative non-steroidal anti-inflammatory options like the targeted biologics or the steroid sparing agents or novel therapies which are available with us, but we need to consider the risk-benefit profile of alternative therapies based on comorbidities, cost and the patient-specific factors before we initiate any of them. So solutions with the emerging pharmacological therapies like the GLP-1s, they cause very good weight loss and good glycemic control. They may be tried, and the advanced insulin delivery system like the closed loop systems, they cause a very good postprandial coverage, and the selective glucocorticoid receptor modulators are still in the phase 3 trials. So the RSTA guidelines also discuss the same points which I've already told you, that you need to monitor the patient, whether they are diabetic or non-diabetic. Patients on IV insulin, you need to look if the infusion, if you're doing, keep checking every 30 to 2 hours. You need to check the blood sugars so that we do not prevent the complications. We need to prevent the complications of hypoglycemia. And we have few research updates where they have compared DPP-4 with insulin. Insulin has found to be more effective for steroid-induced hyperglycemias, and for monitoring, CGMS has found to be more beneficial compared to the standard monitoring, and the Cellgram trial also has shown non-selective glucocorticoid receptors have better anti-inflammatory effect and less hyperglycemia when compared to prednisolones. So before I conclude, I would like to talk on a single point on autoimmune pancreatitis. This is actually a rare type of pancreatitis which actually presents with diabetes. The treatment for this condition is steroids, and this diabetes is curable in this condition with steroids. So the future for our steroid-induced hyperglycemia can be a pharmacogenomic testing, like identifying genetic variants which predict the steroid sensitivity and a hyperglycemic risk, biomarker panels measuring inflammatory mediators, tissue-selective steroids, digital therapeutics, and CGMS will surely help us a lot to prevent the steroid-induced hyperglycemia. So the key takeaways from my talk today will be hyperglycemic risk is about 60%, so we do require intervention. And the peak effect of 4 to 8 hours after intake of oral steroids is a time we should monitor really strongly. And insulin increase is needed by 30 to 40%, and the critical window of 72 hours after the initiation of the steroids, we need to go do intensive monitoring. So the success in managing steroid and hypoglycemia requires proactive planning, appropriate monitoring, timing of insulin and OHA matching, patient education, all tailored to the specific steroid regimen. Thank you very much for your patient hearing.
Thank you so
and
much,
I would like to say a big thank you to my mentor, Dr. Shanmuvelu sir. The best teachers are those who inspire us to be our best selves. Thank you, sir, for being a constant source of my inspiration. Thank you very much.
Thank you, ma'am. Thank you. It was a wonderful presentation. So it's very important that once you start steroids, start monitoring and see to it once it's above 180, you definitely have to start. If it's a short-acting steroid, short-acting insulin, long-acting NPH or glargine, basal insulin, see to it that the sugars are under control. Any question from the audience?
Yeah, just a comment. It's a very nice presentation, fluent and very fast as well. But the thing is that, that we need to understand what steroid you are using, because pharmacokinetics is number one, and then whether it is more mineralocorticoid or glucocorticoid effect, that's the second thing to be taken. Pharmacokinetics is very, very important so that we can plan. But I think we also should think about starting them on DPP-4. You specifically told about GLP-1 receptor analogs. But DPP-4 inhibitors with metformin combination is a very good one. The reason is that metformin will, because whenever there is a steroid, it's a catabolic condition where substrate is available for hepatic glucose output, which can be mitigated by metformin. That's number one. Number two, when there is hyperglycemia, there is increased glucagon as well. So when there is a glucagon level, more hyperglycemia. So the incretin-based therapies are going to be very, very useful, apart from insulin that we are using it.
Yes, ma'am.
When you're talking about steroids, what about the steroids we give in pregnancy for lung maturity? So what do you actually for the treatment, like how long, what is the dosage adjustments you can do with insulin, and how do you monitor during that particular time?
Ma'am, it's normally given with DEXA they give. We started off with insulin solina, ma'am, for that.
Yes,
Yeah, you keep monitoring the patient every 4th hourly and you give the insulins, and we need strict glycemic control for the 48 hours because 2 doses that we give it for the patient.
I think Premal has raised a very important question here. You can see that when you give lung maturity only the 3rd trimester, by then the insulin resistance is already at the maximum from the placental hormones. So at least about 50% of the people by giving DEXA, these sugars doesn't go up too much, like what we think. A small adjustment, because most of these people will be on insulin especially. So I think adjustment of the insulin dose is required on about 30 to 40% of the woman, but 60% you usually don't require any increase because already the hormonal insulin resistance is at the peak during that time.
Thank you, sir. Thank you for your insights. And no more questions. We'll go to the next session. Prevention of type 1 diabetes. Is it possible, reality? So Dr. S. Vengo Jayaprasad from Coimbatore would be explaining to us about.
Very good morning, respected chairperson, my dear friends and delegates. So my topic would be today on prevention of type 1 diabetes mellitus. Is it a possibility, reality, and what are the chances? So let me put you a hypothetical situation and we'll find out the answer. Say today is your wife's birthday and you have forgotten it. And you are coming back home after attending your friend's promotion party and a few drinks. And your wife attends the call, only to be surprised, really surprised. She was expecting a surprise and she is really surprised to see you, like not able to stand steadily. And then she shows her actual avatar formation, Durga avatar, natural. And any Durga avatar will make you remember even your Purva Janma. And then you remember that today is her birthday. And then you tell her to control the damage, I love you Priya, happy birthday. Only to know that, then remember that Priya is not her name. So, now who can prevent the disaster or the oncoming Armageddon? So that is what has been happening to the beta cells once your body has decided to destroy it. So, until today, once the body has decided to destroy your beta cell, it is the same situation that the man faces. But then we as doctors, we cannot just stop short of telling this story to every patient. So we will have to think of something that we can do. So we will have to think of few things like, from the beginning, what can we do to prevent the possibility of having a type 1 diabetes. So primary prevention, so before the onset of islet autoimmunity. Secondary prevention, before the diagnosis of type 1, that means before the blood sugar shoots up. Tertiary prevention, in individuals who have already been diagnosed as a type 1 diabetic, but to preserve residual beta cell functions. And then once the patient has a full-blown type 1 diabetes and still a little beta cell is there, or we try to bring back the beta cells. So is this a possibility? So before that we will find out what are the available possibilities that are unconventional. In type 2 diabetes itself, we have so many options to delay the type 2 diabetes. We have given the patients so many things to prevent and delay diabetes. But how many percentage of patients do follow that? So whatever has been proven and we suppose it is conventional, the patients make it unconventional. So in type 1 even that is not possible. So let us think of preventing the type 1 diabetes onset itself. So we have to find out the incidence of type 1 diabetes in varying parts of the world. Finland mari urla there is more incidence of type 1 diabetes, but in Pakistan it is so less. So if you marry somebody from Pakistan, the chances of getting a type 1 diabetes is less. So number one, unconventional diabetes. But that is not always a possibility, because even in Japan, where we have so many hypotheses in type 1 diabetes like the immunomodulator effect, the immune presentation issues, Japan is a very healthy country. They are not more or less sterile country, but the incidence of type 1 is very low when compared to any other West. So this has been striked out. And then we have the microbial hypothesis for type 1. We have found out that the maternal infections can cause type 1 diabetes mellitus for the offspring. So maternal enteroviral infection can cause 30% increased chance of having a type 1 baby. So if the government and the policymakers decide, there could be some chance of vaccinating or identifying the high-risk mothers for enteroviral infections. And then having a congenital rubella increases the chances. Similar is with the Epstein-Barr virus, Coxsackie B virus. So we will have to take measures to prevent the intrauterine infections of transferring the intrauterine vertical transmission of these viruses. And of course, there has been another microbe theory. The caesarean rates, as it goes up, there is a chance of increased type 1 diabetes mellitus. So bringing down caesarean deliveries is very important, because they say the fetus passing through the genital canal will increase the chances of getting the maternal commensals, and that prevents the type 1 diabetes and prevents the autoimmunity. So that is one another possibility. These are all unconventional and nearly not possible. And again, prolonged breastfeeding to around 2 years has been clearly shown that type 1 diabetes incidence is less among the mothers. And more importantly, now 30% increased chance of babies, sorry sir. Some factual, please excuse me.
I think you are still in the first statement, if it's okay.
Yet to recover the shock, madam. But he can adapt very quick, because he's been frequently used to such situations. So there is 30% chance of having increased chance of having a type 1 diabetic patients offsprings in mothers over 35. So bringing down, getting the baby earlier, bringing down the age of delivery and bringing the babies earlier is one possibility. So these are all the primordial preventions that we can aim. So now could be the genetical intervention. This could be one of the primary prevention options. We all know that type 1 diabetes has a high association with HLA class 2 alleles and other non-HLA alleles like insulin gene, CTLA4, PTPN22, etc. So if we can modify in some or other way or identify earlier and target the kids from giving some healthy intervention which has not been yet postulated, there could be a chance of bringing down the chance of acquiring type 1 diabetes. But this is possible now because we have a chance of delaying the type 1 diabetes from stage 2 to 3 and identifying the kids that can become type 1 diabetes is now very important. So you can see here early screening of these gene alleles in the kids, we have a chance of instituting one single drug that is available today in the market to help us in delaying the type 1 diabetes mellitus. So now after all these things, I am coming to the actual talk, and this is the only slide, the next slide is the only slide that has some meaning to the whole topic, and that is the only way we have today. So the only drug that can be used in delaying or preventing type 1 diabetes is the teplizumab. This is a CD3 monoclonal antibody which is targeted against the CD3 receptors, T cells with CD3 receptors, because we believe the CD3 receptors are the one, T cells bearing CD3 receptors are the one which target the beta cells. So this is now the only approved drug based on the TrialNet study that went on between 2014 and 2018. FDA immediately approved the drug for the use in type 1 diabetes mellitus. There were 3 drugs in the run. One was teplizumab, other was otelizumab, and the third one was golizumab. Of these 3 drugs, Prevention Bio let out their results earlier, and they now have the full approval for being used in prevention of type 1 diabetes mellitus. So we can see now, if we were an Ayush or Ayurveda preparation people, we should have got this drug a decade back. 2014 le vandirukku. Only because we are modern medicine practitioners, we have been waiting for full decade for gaining use into the general market until we do this. But still people think that we are using the drugs that cause side effects. So it has been approved not only by the FDA approved in 2022, but ADA has brought into its guidelines in 2025 or even 2024 that this drug could be used. So the summary of the TrialNet was, it studied around 50 patients of the offsprings who were at high risk of type 1 diabetes patients, and then they found out that there was a genetic predisposition, and they kept following the patients. All the patients who had autoantibodies, the GAD, IA2, etc. presentation, they immediately started giving this drug, and they found that when compared to the placebo, there was 72% decrease in these patients progressing to stage 3 diabetes mellitus. So how is it given? It is given as an IV infusion over half an hour. It is given for 14 days. The maximum dose is given between 5 to 14 days, and it is around 1000 micrograms per square meter. It's just a single dose because it is given as a study. It was given the study. We don't know, and it was found that the progression from type 2 to type 3 was delayed to at least 2 years. So we don't know if we can repeat it again, would it delay it further? So the studies are yet to come. PROTEAT study is the name, and we will have to wait for it. And if we have a clear idea, I think there could be a certain duration until which we can progress or prevent the progression from type 2 to stage 2 to stage 3. So who are the patients who are the ideal candidates? The ideal candidates are the patients who present to us at stage 2 type 1 diabetes mellitus, and we give it, who are of age greater than 8 years. So this is this set of patients whom we can give teplizumab. So there is a basic side effect profile like any other monoclonal antibody. It is a cytokine release syndrome, WBC, the white blood cell depletion, etc. So it comes as a brand name called as ZEAL. So now, once this is not available, do we have any other option? So when the disease has progressed to stage 3, this is the tertiary or late prevention stage. Studies are on for these drugs, like again rituximab, etanercept. All these studies have failed. We have tried IL-1 beta blocker, TNF alpha blockade. All these things have failed. But one thing is promising, that is the antigen-specific therapy. Antigen-specific therapy is building up tolerance against the antigen. What is the antigen here? It could be beta cell or insulin. So giving intranasal insulin earlier or even at the presentation, they say there is a chance of building up tolerance for insulin, and it is not yet worked. But there are 2 or 3 newer like molecules like autoepitopes that are also into the study. So it is not like the doomed situation that the man had, so that there is no recuse. He is definitely going to face the disaster. But as far as the type 1 is considered, we still have a ray of hope, and in coming years we can definitely have promising drugs. Thank you so much for your patient listening.
Thank you so much for the insightful talk. And any questions from the audience?
Total cost comes to around $1,93,000.
அதான் இந்தியன் டைப்பே கிடையாது இது.
Dollars, not in rupees.
It's a single dose.
That's
Yeah.
it. For, course of 14 days.
But is it successful still? Yeah.
But then you will be waiting it. There is a chance of even preventing the disease, isn't it?
So is there a role of gene therapy? Because so many genes involved.
No, madam. As
at
of
present,
now,
not.
no. If madam will allow for next 5 minutes, I can call you up on stage. Another 5. Thank you, madam.
Thank you. Thank you so much. So the next talk is on mitochondrial targeted therapy in diabetes by Dr. Uttara. She is a consultant diabetologist, Dr. Mohan's Diabetic Center, Gopalapuram. Over to you, ma'am.
Good afternoon all, and I think after this session you can all walk out with me together because it's the last session here in this lab. Thank you, Chairperson, and thank you for the mixed bag session where we had different kinds of talk. So moving on to my talk, this is sponsored by Zydus, and so I think to a DAISICON group, I don't think I need to talk about the burden of diabetes and so on. You've heard enough. But what we shows here, you might think, what is it? Isn't it wrong? Isn't China still the #1 in diabetes, capital of the world? We are the #1 in the untreated diabetes. Undiagnosed diabetes. We are the #1 capital in the world. So the burden comes in from there, and the numbers are, even the younger diabetes are much, much higher. So if you see 53% are unaware. Of that 53, if you see 58% are untreated. Okay, if you take the 42% treated, again only 25% achieve the optimal control. We have the START study, the INDIAP study, everything saying that the average A1C is somewhere between 8.3 or 9.5. This is, we're talking about people who've been diagnosed and on treatment with a lot of our successful practitioners. So the basic, because why is it so? Because diabetes per se is not unifactorial. Just like my previous speaker did mention, when type 1 diabetes itself, you cannot pinpoint a gene or you cannot pinpoint one pathology. Type 2 is again a multifactorial, multipathogenetic, but the 3 main things is the beta cell dysfunction, insulin resistance, and gluconeogenesis. I borrowed this slide from my son. Okay, this is my 10th grade mitochondria. What are the functions of mitochondria? And I think we can do better. So these are the 3 major functions of the mitochondria which are relevant to diabetes. Why are we talking about? Because mitochondria is a very dynamic organelle, and I don't think it's only diabetes will be discussing mitochondria, and you can take across specialties, all NCDs, just like how insulin resistance combines the common soil hypothesis. Mitochondria could be a picture with even healthy aging everywhere. Mitochondria plays a huge role, and the development of type 2 diabetes, if you see the cell function, ROS production, apoptosis, ATP generation, these are the things where it is related to, relevant to diabetes care. So there are enough studies which have shown that in a diabetic, the structural the functional and also the molecular level changes in the mitochondria. When there is diabetes in a patient, the mitochondria get altered in such a way that it can lead on to increase ROS production, increase lipid accumulation, and cardiac dysfunction, especially in the heart, pancreas, and the hepatocyte. This has been predominant in type 2 diabetes. So what can happen is, because of this, there will be a decreased beta cell mass, decreased insulin production, decreased secretion of similar secretion coupling, and thereby, because mitochondria, as I said, is a very dynamic, unless consequently it is having fusion and fission is happening, then if that is slowing down, especially as we age, it slows down, and age is accelerated when we have diabetes. So the mitochondrial health, or the mitochondrial structural functional, is affected because of diabetes. So we know we have an armamentarium of drugs, and you have your clinics bombarded with reps and so on, with different companies coming in with all our armamentarium. The target tissues, if you see, are commonly the adipose, skeletal muscle, pancreas, kidney, liver, and intestine, right? But remember these three things I told you, the main pathogenesis. So there is a need for a drug that can address the mitochondrial dysfunction as a major root cause, because that could also be a root cause for diabetes. Because if that happens, it can protect the beta cell mass, thereby increases insulin secretion, thereby improves the insulin resistance, and also reduces the gluconeogenesis in response to glucose. So this is the first of the group of oral tetrahydrotriazone compound. This is the glimmin group, they call it. So this is the first introduced, approved, novel drug approved, first introduced in 2021 in Japan, and then DCGI approved it in 2022. And why am I talking about this? Is because it's different from the other drugs, because it improves the beta cell function, insulin secretion, also the insulin sensitivity, and also reduces the hepatic gluconeogenesis. All three of the most important mechanisms are handled on because it acts on the mitochondria. Then do we have any trial? Do we have any robust backing up for evidence to say so, or it's just because it's a sponsored talk? Available clinical evidence also I'll be presenting to you. There are 3 times trials, which all of these are from Japan, and I'll also have an Indy time trial, which is it. So when you look at the mitochondrial energetic, as I told you, the more enhanced impact is on the liver, skeletal muscle, and the pancreas. The mitochondrial disruption happens in diabetes and these muscles, and you do know, because of a multiple cascade of cellular metabolic pathway, especially by increasing the NAMPT, NAD, and the calcium channel, it can impact the glucose utilization in the muscle, decrease the gluconeogenesis, increase the glucose utilization in the liver, and increase the insulin secretion and decrease the beta cell apoptosis in the pancreas. So it is actually a novel and unique dual mode of action, having both the insulinotropic and the insulin sensitizing property. I have evidence for that. So when we look at the insulinotropic index, insulinogenic index, which is a little much more complex index than the HOMA beta or the HOMA IR. It's not used usually, even in the research model, across the GTT, they do a GTT and look, because it's a more of an a dynamic model. It's not it's a HOMA IR, HOMA beta, or one time assessment. This is like a series of assessment. So it gives you a better value about a drug. So the insulinogenic index, if you see the area under the curve from 0 to 30 minutes for insulin, by area under the curve for 0 to 30 minutes for glucose, and over a period of 18 weeks they look at the baseline change, and you can see very well here in the bar that imiglin had a better insulinogenic index. So the lower the insulinogenic index, the higher the risk of developing diabetes. So the higher the insulinogenic index, it is a better. And what about the Tumwall index? It is again which shows the secretory effect of sensitivity effect of insulin, and this index also was much better on imiglin treatment for across 18 weeks. So all of the time trial I told you, what they did is that they had 3 doses. One is 500, 1000, and 1500, and they wanted to look at how is the A1C reduction, and they did find excellent reduction. But if you see the difference between 1000 and 1500, not much. So that's why they thought it had no more to promote on 1500. They stopped with 1000 mg, and they started all their trials. Everything was done only with 1000 mg BID dose. So So I'm going to present to you the times 1, times 2 and times 3 trial as just 3 slides about what they did and what did they find out. All of these 3 trials are done in Japanese population. So the aim here in times 1 is to look at the efficacy and the safety of Imiglan. So they had a A1C range of 7 to 10%, and they gave 1000 milligram BID, and they looked at the reduction for about, they looked at the A1C reduction for a period of 24 weeks, and they did find a reduction of 0.87%. So these are naive patients, newly diagnosed naive patients, started on monotherapy with Imiglan, and they got a 0.87% reduction in A1C. The times 2 trial is either they used it as a monotherapy or as a combination therapy. As again in Japanese population, again the A1C ranges between 7 to 10, and but it's a little longer duration. They had it about 52 weeks, and they did find out that if used as an add-on, the A1C brought down by 0.56 to 0.92% as expected because of the synergistic effect. And the A1C, this is the times 3 trial where they used, looked at the safety and efficacy of Imiglan as a combination therapy in either, single drug, dual drug and so on, where they extended the A1C level to 11%. Again, they had 1000 mg BID of BID dose of Imiglan over a period of 52 weeks. Now, what they did at 16 weeks, again, they looked at the A1C, and again at 36 weeks, and at around 36 weeks, they had a 0.54, but again, there was a sustained A1C reduction when they followed up to 52 weeks. So Imiglan continued up to 52 weeks. There was a sustained reduction of 0.64%. So using as a monotherapy, as a dual therapy, or as a combination therapy. So as I did mention, all of those were on Japanese population. So what about Indian? We, every time any trial comes in, it's either a Caucasian or thing. So nowadays there are more and more trials which include our ethnicity and Asian population in the trial to get the global presence. So this is the Indie Times trial by SESHIAH Sheikh et al. And what she looked into is that this was the first and large-scale study of Imiglan in Indian patients. They had around 8,300 patients, and there were around 191 sites across India. This is a 3-month duration trial. Baseline A1C was between 7 and 9%. And what did they do is that in the prescription that they used Imiglan in combination as monotherapy, 24%, Imiglan as dual therapy, 60%, and in combination with 2 or more, triple drug or so on, already on multiple drugs, you add on Imiglan, and were there any difference to it. So they looked at different scenarios which you can use in your clinical practice to find out if the new drug would impact your A1C levels in your patient. So the primary endpoint, as expected, they wanted to look at the A1C, fasting, and the postprandial. There were also other secondary outcomes like the renal. They looked at the renal outcomes, liver, and so on, which I will discuss. Now, the Indie Times study, what they did find out is that A1C from the baseline of 8.07, a 3-month follow-up, it could bring it down to almost 6.96%. But on an average of about 1.12% reduction in HbA1c was seen across the population, and the fasting blood sugar was brought down by 29.41 and the ppg by 62.41 milligram per deciliter. So it did prove to be a very potent drug and an efficacious drug when used as monotherapy, dual therapy, or as triple therapy. And the NNT, or the number needed to treat, or the number of people who are able to achieve this target, because there are usually we think of responders, non-responders, and so on. So here again, 45% of the patient achieved the A1C of less than 7% at the end of the study. So this is the baseline A1C comparison. If you see, they are in people who had a 7 to 8% HbA1c. So we always know, the higher the HbA1c, the better. So many of the drugs, when we give 11 HbA1c as monotherapy, you get more people with 11 HbA1c monotherapy. You will even get a 2%, 3% reduction with the oral drug. But when you have a lesser HbA1c, you do not get that response. So that's why there is always a comparison between a lower HbA1c and a higher HbA1c. Whenever you're choosing a drug, you have to look at the HbA1c reduction in both the groups. So here, if you see, the A1C reduction in 7 to 8% was again almost 0.81% reduction, and people who had an above 8 HbA1c had a 1.43% reduction in HbA1c. So this is as per the treatment groups. If you classify them into 3 different as mono, dual, and triple or more drug therapy, again across the scenarios. So if used as a mono, again 1.12, usually monotherapies will have the highest A1C reduction, and then as a dual 1.10, and then as a triple drug 1.13, because mono usually is the naive drug, drug naive patient, so the response is usually the best. And INDI-TIME study also looked at the fasting and the PPG reduction, so that you did see a significant A1C reduction. Now looking at the fasting reduction of about 27.92 milligram in a monotherapy, 28.86 milligram in a dual therapy, and a 33.6 milligram reduction in the fasting level across the mono, dual or more than 2 drug therapy. And the PPG levels also, so imagine a patient that has a 300 or something postprandial. When you use it as an add-on, they can bring down the blood sugar to 140 and so on. So almost a 64 milligram per deciliter reduction in the PPG levels by adding on this drug as mono, dual or triple drug therapy. Now this is a subject which is across the drug group. So across which drug group does it have the maximum impact they wanted to look into. So with sulfonylurea, they used it with a commonly used sulfonylurea. It had a reduction of 1.15% A1C reduction. So already on sulfonylurea, you add on emiglin, there was a 1.15% reduction. Already on a metformin, and you get a reduction of 1.12, and a DPP-4 1.16, SGLT2 1.11, and with insulin a 0.85% reduction. It is you can use it as an add-on therapy across the drug classes. Some do have a doubt whether it can be used along with metformin and so on. Yes, there are trials. I will talk to you about it. But they had the INDI-TIMES had patients who were on metformin, and as an add-on, emiglin was added on, DPP-4, SGLT2, insulin, and so on. Now the comparison of the mean changes in HbA1c across the overall population, if you see 1.43, mono 1.51, 1.42 and 1.37, re-emphasizing the fact that it is one of a very efficacious oral anti-diabetic medication. And this is the fasting levels reduction. When the fasting levels is about 200, there was a 96.25 milligram reduction in the fasting, 34.67 if 150 to 200 levels of fasting, 100 to 150 almost near normal fasting also, there was a 0.28 reduction. And the PPG reduction, if you see across, it was around 62, and the higher the postprandial, about 250, when you added on emiglin, there was a above 100 reduction in postprandial, that is 120, almost 120 milligram reduction by adding on an additional drug for the reduction of PPG. This is the secondary or the safety profile or the other parameters they looked into. Surprisingly, they did find that the aspartate, transaminase and the SGOT and HEPT did come down, and with a statistically significant reduction. You can see here it is a statistically significant reduction in the enzymes, liver enzymes were seen, and also the lipid profile. If you see the HDL levels improved, the LDL again came down, the total cholesterol again came down by 56.34, triglycerides by 74, all of these gaining statistical significance across the class of drug. Now, serum creatinine also did come down by 0.29. This is an it is not a subset analysis, so they need more data to look at isolated liver parameters and so on, because there's a confounding of glycemic benefit can also be there when this is there, because any drug improving the glycemic benefit, definitely the overall parameters will improve, but gaining such statistical significance warrants further looking into whether it can be a renal, it can be used as for a liver protection, and it's a very good drug in terms of safety. The commonest side effects or the adverse effect profile which they found was the GI side effect, but there are studies even on comparison with metformin. There are around 90 or 100 patients were compared with metformin and this drug, and the GI side effects were much less on comparison with metformin and this drug, but this is the commonest adverse event seen. And also they looked into, there was some smoke about lactic acidosis and so on. Again, they looked in that study between metformin and emiglin, they looked at that, and they did find that the levels were much less or didn't gain statistical significance on comparison to metformin. So the INDI-TIME study summarized that it is a very safe drug. and 1000 milligram BID can be used in your patient, and it could bring down an A1C of 1.12%, a fasting of almost 30 milligram per deciliter, PPG of 62.4. It is a very safe drug. It could improve the renal, liver and lipid parameters, didn't cause any major cardiovascular or any other adverse event. So it can be used as a monotherapy. It can be used as a dual therapy across the class of drug, sulfonylurea, DPP4, HLD2, and insulin, and also as multi-anti-diabetic drug. So all these classes were looked into, and it was found to be safe. So ladies and gentlemen, the take-home message is that you're going to get more and more patients into your clinic with diabetes as people age more, and they're going to be more and more. The whole idea is to prevent diabetes and prevent its complication. So that can be done only with better control of sugars and having your basket wide enough to pick and choose which are the best drug for the person sitting in front of you, your patient. So currently the challenges are insulin resistance, gluconeogenesis and beta cell dysfunction. Mitochondria could be a very, very important organ in the disease pathogenesis across the NCD sector, and oncology, all of this is already exploring this side. The mitochondria are highly dynamic organelles and the main source of ROS in the organism and control the cellular homeostasis, cell death and apoptosis. So imiglin is most significant difference from the other medications is that the mode of action per se, the fundamental approach of correcting the mitochondrial dysfunction, that is also a cause for type 2 diabetic. And imiglin targets both insulin secretion and insulin resistance by correcting the mitochondrial dysfunction. It also rebalances the activity of the mitochondrial respiratory chain, thereby reducing the oxidative stress. And you all know this term, oxidative stress, can hold a lot of meaning across multiple pathogenesis. And imiglin simultaneously targets all three key organs of diabetes, namely the pancreas, liver, and the muscle. And it has been improved long-term cell benefit because of the reduction of the apoptosis level and the beta cell protection. Imiglin has demonstrated broader protective effects in the preclinical studies. These are not yet proven, but there are some newer info coming up about the prevention of neurodegeneration, cardiovascular and renal, but it has not been approved in those sense. It's just a preclinical studies in animal models. And imiglin demonstrated good efficacy with monotherapy. So you can use this drug in a naive patient as a monotherapy or as an add-on to metformin, or as an across any other class of drug, and also along with insulin. Thank you all. Thank you for your patient listening.
So thank you, ma'am. It was a wonderful presentation on imiglin. Any questions from the audience? I think no more questions. Thank you so much. It was a wonderful mixed baggage session. I hope you all would have got a lot of insight into the newer managements of diabetes mellitus.
How cost it, madam?
Sorry?
How cost it?
It cost around 16 rupees, right, sir? Yeah, 16 rupees.
16
Around 16. I think 500 is lesser, 12 or something. And 1,000.
with only 1 gram
1 gram BD. Yes, the effects are seen only with 1 gram. 500 also did show the as well. 500 OD also you can, depending on. But 1000 milligram BID is what all the trials had looked into.
So it is a mitochondrial dysfunction. So it corrects the mitochondrial dysfunction is very, very good drug.
Yes,
actually.
That is.
Nowadays,
they need more backup of evidence. Even though they sponsor, I think they need more evidence, like the cardio. They don't have a CVOT trial and so on. Nowadays with the CVOT trial, but they are sure coming up. But I think it's a very novel, addressing the novel pathogenesis of diabetes. And mitochondria is novel only to diabetes. It is not novel to oncology. It is not novel to any other field of medicine. So addressing the mitochondrial defect is definitely well versed, and they have a lot of robust data on that. But in terms of glycemic benefits, they are the first to come out with it. And I think with more and more backup of evidence, I think this should be very one of the
best
choices
drug.
We can definitely think of, one of the very important
completely
choices.
different modality of drug. Thank you, madam. Thank you for highlighting this.
Latest cost is 1000 milligrams,
10 rupees, 10 rupees.
Okay, good.
That's what I was saying.
Okay, very cost also very effective.
Yes, very important. Very useful.
Thank you.